This is the third and final installment in a series of panel discussions around race issues in Baltimore County. As a facilitator of these programs, the Baltimore County Public Library, along with our wonderful collaborators, the Baltimore Human Relations Commission, Baltimore Office of Equity and Diversity, and WEAA 88.9 FM, Morgan State University Radio. Together, we have established a goal to critically discuss policies and practices to advance equity in different realms. Policing outcomes for minority communities in the first panel discussion, and voter rights toward ending voter suppression in our second program. Along the way, we have explored how poverty, education, and lack of access to resources exacerbate the panel topic issues, further creating barriers to justice. So why have we decided to explore health equity as a final topic tonight? Simply because the right to health is where all other rights converge. Illness and unequal access to healthcare interferes with everything we want to accomplish and curtails our abilities, our strength to fight forces, deferring our goals and dreams. According to research by the National Institute of Health, African Americans and other disadvantaged racial and ethnic groups, individuals with less education, income, low-wage occupations, and those in rural areas are less likely to have health insurance, have poor access to healthcare, and receive poorer quality healthcare. So eliminating health disparities will require us to address social determinants of health, such as safe, affordable housing, structural and institutional biases, and racism. And we're on the right path to solutions in convening these kinds of discussions and conversations. We are trying to amplify voices, and we have developed a lot of new partnerships through this effort, supported by you, our audience. So let me introduce to you one of our newest community partners, Sonia Almonte, the communications specialist at Baltimore County Department of Health and Human Services. She's going to talk about tonight's topic, and she will introduce our esteemed moderator. Welcome, Sonia.
Thank you, Brenda, and thank you all for joining us this evening. Again, my name is Sonia Almonte, and I work with the Baltimore County Department of Health and Human Services. As a culmination to our Dialogs on Race series, we are here for an illustrious panel of local healthcare leaders across specialties to galvanize us towards advancing health equity. This year, the American Nurses Association declared racism as a longstanding public health crisis that impacts mental and physical health. With COVID-19 exacerbating the longstanding systemic health and social inequities that have severely impacted many racial and ethnic minority groups. For example, between March and May in the Johns Hopkins health system, 42.6% of Latinx patients tested for COVID-19 had positive results, compared to 17.6% of Black patients and 8.8% of white patients, according to a report published in the New England Journal of Medicine. These case trends are concerning as we're experiencing yet another surge of COVID-19 cases with a positivity rate in the county at 7.33%. Your voice matters to us. After the program, we invite you to complete our community health needs survey to identify ways to improve health. The link will be made available in the Q&A section and posted in the Facebook livestream comments. A reminder that the last day to complete the survey is December 11th. Without further ado, I would like to introduce our fantastic moderator for the evening, Farajii Muhammad. Farajii Muhammad is a media personality with special skills in community organizing and nonprofit and non-professional management from Baltimore. Throughout Baltimore, Farajii is known as humble in spirit and high in energy. As a community servant, music artist, writer, and speaker, he has used his passion for young people to advocate for their concerns. Farajii made his mark in broadcasting 15 years ago as creator and host of Listen Up, that aired from 2005 to 2017 on WEAA 88.9 FM. From 2015 to 2016, Farajii was invited to Radio One Family by Miss Kathy Hughes herself to serve as a co-host for the Larry Young Morning Show. With this platform, Farajii used his brand of blending political and social justice knowledge with satirical humor and cultural insight, and became a needed voice about issues for the next generation leadership. Topics ranging from police brutality, politics, and education, and more. He has been a guest on CNN, Matter of Fact, NBC, NPR, and other news outlets. He formerly served as TV One's News One Now with Roland Martin and NPR's All Things Considered as a contributor. Currently, Farajii is the host of the Associated Press award-winning daily news and cultural show For the Culture that airs on Public Radio 88.9 FM. On For the Culture, Farajii has discussed many topics ranging from politics and education to health, Black arts and culture. Welcome, Farajii.
Thank you, Sonia, and thank you, Brenda. Thank you to all of the wonderful team and the staff of the Baltimore County Public Library System. We're very excited and very honored to be a part of tonight's conversation. I wanted to at least get the ball rolling because there is so much concern about where we are right now with COVID-19. And, you know, we're having this conversation at a time when the state has officially announced that, and not just COVID, I'm sorry, advancing health equity, but we're having this conversation at a time when the state has officially announced that the state of Maryland has surpassed the 200,000 coronavirus case mark, which is a grim milestone, especially given the fact that we have been involved or have been, impacted by this pandemic for at least 8 months. And we are still seeing a huge surge in cases, new cases, each and every day. That it's still a big conversation for us to have about social distancing. There's still a big conversation for us to have about washing your hands. And it has become a political conversation just as much as it is a public health discussion to wear masks. And so on top of that, we're dealing with all of the other inequities that exist in the healthcare system. And it's going to be important that we have some guidance on how to navigate through the conversations as well through this very, very complicated, intricate, and sometimes very, very disheartening system to get to some level of equity and justice. And so tonight's conversation is going to be an attempt for us to get a little bit further along in that mission. I'm so excited to have with us, joining us, some esteemed panelists to give us some insight on how we should move forward looking at the healthcare system. We wanted to introduce to you the director of the Baltimore County Department of Health and Human Services, Dr. Gregory William Branch. He is a native of New York City, and he has graduated magna cum laude from the State University of New York at Buffalo School of Medicine and Biomedical Science. He completed his training at the Johns Hopkins Hospital in the William Osler Internal Medicine Residency Program. Dr. Branch, thank you so much for being a part of tonight's conversation.
Thank you so much, Farajii. I'm glad to be here. A virtual fist bump to you and everybody else.
Thank you, sir. We're also joined by Dr. Jin Joo, and I want to make sure we say her name properly and correctly. Dr. Joo is a geriatric psychiatrist and health services researcher in the School of Medicine at Johns Hopkins University. She provides memory care and clinical psychiatric services to a diverse geriatric population here in Baltimore. Her research and interests include alleviation of health disparities, use of mixed methods in intervention development, and development of psychosocial interventions involving peer mentors to alleviate depression. She is the principal investigator of a career development award from the National Institute of Mental Health devoted to developing interventions to increase engagement in mental health services among elderly minority communities. Dr. Jin Joo, thank you so much, ma'am, for joining us for the conversation.
Thank you so much. It's really excited and honored to be a part of the panel.
Absolutely. And then we're also joined by Mr. John Torsch, who is a harm reductionist and peer recovery coach. He is the director of special programs for the Daniel Carl Torsch Foundation, a Baltimore County organization providing drug overdose prevention and awareness, in addition to support for those who have lost loved ones to addiction. Very, very important work. Mr. Torsch, thank you, sir, for joining us.
Thank you. I'm happy to be here.
Also, we're joined by Ms. Kerry Graves, who serves as the executive director for NAMI Metropolitan Baltimore, which is the National Alliance for Mental Illness here in Baltimore. In her role, she provides leadership for the Metropolitan Baltimore's chapter mission of improving the lives of individuals and families affected by mental illness. NAMI Metro Baltimore is one of the largest and most active local affiliates of NAMI and is the nation's largest grassroots mental health organization. And before coming to NAMI, Kerry served as the Vice President of Development for the DC, Maryland VA chapter of the ALS Association. And she joined the NAMI Metro Baltimore team in 2018, bringing over 10 years of experience in health advocacy and nonprofit management to the organization. Ms. Graves, thank you so much for being a part of the conversation.
Thank you so much for having me.
Absolutely. And then we're also joined by Ms. Sharon McClernan, who is graduated from the College of Notre Dame of Maryland and Baker College for Graduate Studies. She is a visionary executive leader who understands healthcare reform, integration strategy, and value-based care. She also has earned an MBA and BSN from the College of Notre Dame of Maryland, and she currently serves as the Vice President for Clinical Integration. She is responsible for integrating programs and services that drive down the total cost of care and improve quality for over 200,000 lives through value-based care and the CMS total cost of care model. She demonstrates a proven track record for building the relationships necessary to coordinate care across multiple healthcare entities and providers. She also serves on the faculty of the University of Phoenix, where she educates students on healthcare strategy and communication. Ms. McClernan, thank you so much for your time and being a part of the conversation.
Very happy to be here. Thank you for having me.
Absolutely. And last but certainly not least is Ms. Lawanda Williams, who has been employed with the Healthcare for the Homeless for 10 years and served as its Chief Behavioral Health Officer. At the downtown Baltimore site, she provides oversight and vision for the behavioral health, case management, community health, outreach, and psychiatry departments. During her tenure with HCH, she has served in a number of roles with increasing levels of responsibility and program oversight, including clinical case manager, lead case manager, program coordinator, and director. She obtained her associate degree in human services with a concentration in substance abuse counseling. She later attended the famous, the all-powerful Morgan State University, where she obtained the BSW, MSW, and MPH degrees. She also teaches here at Morgan State University as an adjunct professor in the School of Social Work. Professor Lawanda Williams, thank you so much, ma'am, for being a part of the conversation.
Yes, thank you for having me. A pleasure to be here.
Absolutely. Dr. Branch, we're going to start with you, sir. We're going to jump right into it because when we're talking about healthcare, health inequity, we got to look at the current pandemic that we are all challenging facing, which is COVID-19. First and foremost, Doc, I want to just ask for the record, how are you feeling since you're out with COVID-19?
Farajii, thank you for asking. I am doing extraordinarily well at this time. So I feel extraordinarily blessed for having been able to come through COVID at this time. So many people have gotten COVID and have actually died from the disease itself.
Yeah.
And so I'm doing well. I have no what we call sequelae or long-lasting effects of the disease itself. So I was able to pull through and to do very well. So thank you for asking.
Absolutely. I'm glad to hear that you are doing much, much better. Dr. Branch, let's talk about this pandemic, because COVID has, some people say that COVID just kind of broke open Pandora's box and has forced us to come face to face with health injustice and health inequity. For example, here in the state of Maryland, we have just been reported that 200,000 COVID cases, and we're seeing that these daily surges of well over 1,500 cases a day. But that is impacting Black and Brown and Indigenous communities much differently and much more on a much more hurtful level than it has in white communities. Talk to us a little bit, Dr. Branch, about the impact of COVID on Black and Brown and Indigenous communities, and how should folks really move forward on addressing this, especially if you're a part of those communities?
Right. So first and foremost, let me say that COVID-19 is here, and there is no major treatment for COVID-19. We've got a few things, but there's no major treatment in regard to that, and it is potentially deadly. COVID-19 hit us, and it's a game changer. It's a new virus that no one was immune to. However, it did not and does not affect us equally. When you look at the numbers, some people may say, oh, well, the numbers are not that bad for persons of color. But when you look at the rate and looking at how it affects those communities, clearly, by far, the Hispanic population clearly is being very much affected by COVID, and then the African-American population. And the African-American population is very much being affected, especially as it relates to the numbers of deaths because of this. So the first thing I want to do is be able to dispel the myth that COVID-19 is not real. It is real. I have experienced it myself. So I'm telling you, this is a real disease. And the fact of the matter is, at the beginning of COVID-19, we did not know about this disease. So we were learning as much as we could, as quickly as we could. What we know now is that there are 3 W's that you should actually do. 1, watch your distance, 6 feet between anybody else and yourself. 2, you've got to wear your mask. And 3, you have to wash your hands. Those are the 3 W's that are very important. I do want to also say that you have to assume that everyone that you come into contact with who's not in your household is positive for COVID, period. You have to make that assumption. You've got to wear your mask. It's important. It's a form of respect, not only for yourself, but for other people. This is real. We have got to, in these holiday seasons, we have got to not be with other people who are not in our households. We've got to do that. The reason why we've got to do that in 2020 is because in 2021, when we do get together, we want to make sure that our loved one is not missing.
And I'm so happy that you mentioned that, Dr. Branch, because I feel like there has been, I think we have all kind of gone through this kind of up and down feeling and sentiment around COVID, and particularly, especially within the Black community. When I travel throughout the city of Baltimore, if you go into certain Black neighborhoods, some people are wearing masks, others aren't. They're in close proximity to one another, the whole 9. But then when you look at the number of hospitalizations, when you look at the number of those who are with, have to receive ICUs and all of those things, the difference and the stark reality hits you in the face. And that's one of the big things I think that we should kind of key in on. Let's talk about the level of this, the evidence of this health disparity. Are there differences in the outcome, for example, between white Americans and Black Americans, especially when you're talking about addressing a major pandemic like COVID-19? And how can people use that, not just as talking points for conversations, but essentially becoming empowered to make better choices and better decisions for themselves, their family, and for their community?
It's so important. I think that when you look at COVID, we're going to talk specifically about COVID, we can tell you that persons of color are getting COVID at very much higher rates, especially in the Hispanic, Latinx community and the African American community. But we also can see that deaths are much higher in the African American communities and also in the elderly population. And we see this because we're thinking at this particular time, as it relates to the severity of the illness and the deaths, that underlying medical conditions predisposes you to having a worse outcome because of COVID-19. We've got to understand that. I recognize that some of our young people think that they are invincible. But what they don't understand is they are carriers of a disease, and they are infecting their family. They're infecting their loved ones. And we've got to be able to say to them, hey, wake up and understand that this is a deadly disease that you personally may not die from. You personally may not even know that you actually have it, but you can give it to your grandmother. You can give it to your aunt. You can give it to your uncle. You can give it to your child. And so it's very important that people understand the importance of this. Unfortunately, in the United States, in the year of 2020, there doesn't seem to be that same communication from the top of our country all the way down to the bottom. It is so important. You cannot have people out there doubting or putting in negativities about a disease. We all have to say to ourselves, this is affecting us all, and I am my brother's keeper.
Dr. Branch, thank you so much. I want to bring some of our other esteemed panelists into this conversation as well. Dr. Jin Joo, Associate Professor of Johns Hopkins University Division of Geriatric Psychiatry. Dr. Branch emphasized that W of making sure that we keep our distance. And that seems to be an effective measure in minimizing the spread of the virus. However, Dr. Joo, it may have detrimental effects on mental health, especially for adults over the age of 65. I've heard reports that this is a very, very tough time for our seniors and our elders, especially when they can't have that one-on-one contact. How can we prevent social distancing from becoming social isolation, especially among such a vulnerable group of citizens?
Yeah, so social isolation and being alone is such a problem always for seniors. And what's happened with the pandemic is that seniors, of course, can't see their family, but then seniors can't see their service providers either. So they can't see their doctors, they can't see, go to the program like a medical daycare center or a senior center. And so all of these services and people that they were depending on and connecting to are gone. And what I'm seeing in the clinic often is that they are getting depressed, they're getting anxious, and they may be having a lot of fears about getting infected and going outside, but they're having a hard time sharing it. So the thing that people are using to communicate is technology. And there are some seniors who are really very good and some who are open to learning, but sometimes it's a barrier as well, because they may not know how to use Zoom or use FaceTime. They may not have the technology or the Wi-Fi at home, depending on who you are. And then they may not have the people around them who can help them, or they can't because they're afraid to be in touch, and families, of course, aren't visiting regularly. So it's been really difficult, and I'm seeing a lot of people have suffering and having increased depression, increased anxiety because of it. So, I mean, right now we are resorting to technology, but it can be, of course, telephone calls, it could be Zoom calls, it can be sometimes, I know that people may not be using the mail that often, but I have to say in my research studies, where that might be the only thing that we can use is mail to communicate with people. And sometimes it's you know, maybe better than nothing. So checking in regularly, making sure that they feel cared for and that someone is looking out for them. And definitely making sure if they have any specific needs as well is really, really important.
Dr. Jen, I know that, you know, this series has been on race, but I want to, you know, just kind of broaden the scope here, because I can only imagine, you know, as a young man like myself, as I deal with, you know, looking through the healthcare system in terms of determining the plan for my family and what's best and all of that, that has to be super overwhelming for, you know, seniors, especially those who are already battling pre-existing conditions. Talk to us about, you know, the equity that is required for seniors to navigate through such a complicated, convoluted system like the healthcare system that we currently have.
Yeah. So I don't, you know, kudos to you if you could navigate the health system, because I find it difficult too. I mean, you know, when healthcare providers have loved ones, of course, they know to some degree how it works, but it's so complicated that it's hard for anyone. So imagine an older adult who may have physical disability, may be feeling a little anxious and depressed during this time, who may have medical conditions that they have to manage. And the healthcare system is telling them, you've got to come and connect to us remotely. You know, you've got to Zoom in, or you've got to use video. That's can be really scary, because they may not know how to do that. And again, they may not have the technology to do that. And I know that I've had some patients who just, even though they may have had an iPad, there was nobody who could teach them. And so they were stuck. And so there's a lot of fear that, you know, that they can't use the services that are being made available by technology. And I think probably it's a lesson, and a healthcare system may adjust to that. I know in the research setting that there's a lot of focus on making technology more accessible to underserved groups, to elderly, of course, who are underserved. So that in the future, you know, we may be able to alleviate definitely the gross inequities that are kind of coming to being because of the fact that we have to connect through technology.
I would think, Dr. Jen, very quickly, I would think that since we have growing generations from baby boomers to previous generations who are getting older, that the system would get a little bit easier. It's now, it seems to me that the system almost wants people to be in a space of confusion and uncertainty. Is that do you have the same type of sentiment about it as well?
You know, I think probably health systems kind of grow kind of ad hoc. They grow in ways that just at certain times it's not planned, you know, by a mastermind to make it simple for people. I think as the younger generation does grow older, I don't necessarily think the healthcare system will become less complex. Only if healthcare systems try to become less complex, I think, will that happen. But in terms of technology, maybe the younger generation will be more adept and familiar with that.
Yeah.
Right now, what's happening is that, you know, community health workers and kind of health systems are using paraprofessionals to reach out to underserved groups to make it easier for them to navigate healthcare services, and also people who are a little less intimidating, who might be able to engage them a bit more, especially underserved communities, you know, within Baltimore, even nationally. So I think there is a kind of momentum to increase accessibility and make the healthcare system a little easier to use. There's still a lot of work to be done to achieve.
Absolutely. Absolutely. Dr. Jin, thank you so much. Folks, just wanted to put out a reminder that if you have questions, we will be getting to your questions shortly, and that we can pose to all of our great panelists. So you can post those questions on our YouTube and Facebook and all social media, and in our chat on Zoom, because we would love to hear what you have to say. Mr. John Torsch, co-founder, director of special programs at the Daniel Carl Torch Foundation. Speaking of vulnerable populations, you work with people who are trying to get their lives back on track from drug addiction. Talk to us a little bit about the work that you're doing in terms of how harm reduction programs can help to improve health equity among those who have been affected by drugs.
Well, at the core of harm reduction is meeting people where they're at, as we like to say. So one of the major ways that harm reduction programs can improve the equity is by bringing it directly to the people that we're serving. Services such as hepatitis C and HIV testing, wound care supplies and hygiene supplies. Some of the more advanced programs that actually have nurse practitioners and nurses who are able to come into the community and provide on-site medical care. Being able to provide the one-on-one support and instructions and COVID-related protocols, how to reduce the harm of contracting COVID-19, distributing hand sanitizer, encouraging the use of masks, and describing, really breaking down, like Dr. Branch did so eloquently, just the seriousness of COVID. And you know, a lot of people who are living on the street, you know, they're in survival mode 24/7, so they already have so many other barriers and potential illnesses and challenges weighing over their heads. So when you throw another one like COVID-19 on top of it, it really just adds, you know, to the compounding problems that they're already having. So we've really stepped up. I would say most of what we've done in response to COVID-19 is really increasing our presence on the street, where a lot of the government-run programs have had to pull back because of protocol and insurance liabilities, which is understandable. And the CBOs, the community-based organizations, have really had to step up with their volunteers and get even more out in the street, fill our backpacks with more supplies, really pushing the mask, pushing the hand sanitizer, flooding the streets with naloxone, because one of the other residual effects from the lockdown and from the closing of the borders and the Mexican border is fentanyl has already changed the game in the last couple of years. But when you compound that with even more restriction and even more uncertainty in the drug supply, it goes even beyond the fentanyl that was being cut into these drugs. And now we're seeing lots of research chemicals and other drugs beyond the fentanyl being cut into the other illegal drugs. That's not just heroin, you know, cocaine, crack, MDMA, methamphetamine, synthetic cannabinoids. Fentanyl is in basically everything that you're going to find out on the street. So, you know, we've stepped up with our fentanyl test strips. They're fairly accurate, as long as, you know, you give people accurate information on how to use them. Again, flooding the streets with naloxone and just making it as low barrier as we can, making sure everyone who could possibly need it has it, and just doing our best to encourage resources, just letting people know that we're there. We're essentially the connectors in the community. So we just let people know that there are options. There are dozens of treatment centers in the area and around the state that we work closely with, and help is never much more than a phone call away.
Mr. Torsch, is there a concern for with you and your team, sir, as we look at this, you know, the distribution of vaccines, the impact that would have in terms of the possible addiction to vaccines, or the impact that may have in terms of the medical impact that it has on those who are already struggling with drugs, and all that are trying to get their lives back? Is there a concern that more trying to, I guess, bringing more drugs into the conversation is maybe a problem for some?
Well, unfortunately, you know, many people who use drugs have a profound distrust for the healthcare system as a whole, in physical and mental health. And even some of the community-based programs that serve them and are there to serve them, who they've been either, you know, failed by in some way or kind of slipped through the cracks. So there's an apprehension already to to seek healthcare services for even things as basic as wounds or the flu. So when you tackle on something like COVID-19 and the potential of another vaccination, I don't know. I can't say for sure how optimistic people who use drugs are going to be because of their the stigma that they faced for so many years in the system, the trauma they've experienced from first responders and healthcare workers. Not all, don't get me wrong, not all healthcare workers, but most people who use drugs, and especially those who are on the street, have had many negative effects. So I would say that there's a distrust, and it's going to be an uphill battle to get that population to vaccinate against COVID.
Wow. Wow. Ms. Kerry Graves, Executive Director of the National Alliance for Mental Illness here in the Metropolitan Baltimore area. Ms. Kerry Graves, talk to us a little bit about, how do we have conversations of this magnitude in a way where people feel comfortable listening to Mr. Torsch, Dr. Branch, Dr. Jin. There is some real anxiety around what's happening right now. There's some real anxiety around vaccinations, COVID, the prolonged impact of COVID-19. There's some anxiety around people losing jobs and businesses are closing and a whole lot of other things. Mental health, mental illness, I would think should be a top priority. Is that the case right now? And is the system, the healthcare system, seeing that as a major issue, a major priority rather?
Yeah, it is a major issue right now. I mean, that you have hit it on the head. I don't know many people who can say that they aren't experiencing some kind of anxiety right now from this pandemic. There are reports after reports that are showing the increase of suicide rates, of depression, of anxiety, and it's just ongoing, right? And so, certainly it is an issue, and certainly there's a lot of talk about it. We hear about it more in the media. There's certainly more buzz around mental health, but what still exists is the stigma, and the stigma hasn't been broken down yet, and that needs to be a priority. Dr. Joo already addressed that there's access to care and issues with navigating the system. But no one's going to access that care if the stigma still exists and if we don't first break down that barrier. Within different cultures, there are different perceptions about mental health, and within the Black and Brown communities, stigma is even more prevalent. It's prevalent within every community, but it is more prevalent within those communities. And then you compound that with the other issues like the distrust in the healthcare system, lack of insurance, lack of providers with cultural competency. Me as a white woman going to try to find a psychiatrist, I'm already going to have a hard time because navigating the healthcare system, and especially the system and finding psychiatrists or psychologists or mental health providers, is already so challenging. But if I am a Black woman or a Black man who is trying to find someone who looks like me and has the same background as me and the same, maybe similar experiences that can relate to me, I'm going to have a much harder time. 86% of psychologists are white. So
is that in the state of Maryland, or is that across the country?
That's across the board. That's not just in the state of Maryland.
Okay. Wow.
So we're going to have a really hard time, in these communities trying to find care, even if the stigma isn't there. So it's twofold, right? We've got to break down the stigma to have people accept treatment and have people want to accept treatment. So right now, again, talking about numbers across the board, individuals who have a mental health condition that seek treatment, where you're looking at about 40% of individuals that actually seek treatment. And when you compare that to the African-American community, you're talking about 25%. So that statistic lowers. And with the Latinx community, you're talking about 22%. And so those communities are not accessing care, even if it was available there. And a lot of that is due to stigma. And so what we try to bring at NAMI is the peer perspective. And so most of our programs are based on sharing lived experience. We have volunteers in the community, 200 volunteers in Baltimore City and County, that share their personal lived experience with a mental health condition, to allow others that freedom to share their own experience. And that's what's so important. You mentioned, you touched on it there. How do we address this? I think the first step to addressing this is conversations like this. And making it acceptable to say, I have a mental health condition. I'm not doing well right now. I think it should be okay for everyone to acknowledge how they are feeling due to this pandemic, and being able to express that in a way that allows them the freedom to want to go and seek treatment.
And I guess, Kerry, that when I hear that, the thoughts that cross my mind is the system really serious about healing people? Yeah. And I mean, I read a story, and I think it was in the New York Times maybe a few weeks ago, and they were making a point that 8 million people ended up on unemployment within the past 8 months, right, in this country, 8 million. And I'm thinking to myself, to come from a place where you're kind of getting by, or you're living, and you're paying the rent, the car, to getting to a space where you're trying to literally figure out how to get food on the table because you lost your job and all of those things. Like, is the system really ready? And are we, and what do we need to do? You're saying having conversations, but there seems to be something else I feel like that needs to happen, because I feel like the conversations are still so high above the pain and the struggle of Black, brown, white in this country, that it's become more detrimental than it is helpful.
Yeah, well, Farajii, you're exactly right. I mean, there are other areas of the system that are broken that all tie into this. And when I say talking about stigma and breaking down stigma, it is across the board. So you've had conversations here as part of this series about the police, right? And about police interaction. For Black, Indigenous, and people of color, they are overrepresented in the criminal justice system. And so rather than receiving treatment for their mental illness, they are incarcerated because of their symptoms. And so until we can address, trying to divert people from the criminal justice system and into treatment and into getting treatment for their mental health condition, right, you're still going to end up with the same issues. It's going to go into a cycle. And so you're right, there are things that we have to put in place first. At NAMI, we provide training to police officers on stigma reduction. We provide crisis intervention training to both Baltimore City and Baltimore County police officers so that they know how to respond to crisis situations and can identify what someone with a mental health condition might be looking like, might be acting like, and might be able to divert those individuals away from criminal justice and get them treatment rather than handcuffs. And so it's no different, I think when we're looking at jobs as well, you touched on how the job insecurity can lead to mental health issues as well. We have to look at, why that job insecurity is there in the first place, and is there discrimination in the workforce, and how do we address those issues? And so I do think there are pieces in place that all have to, fall in line, and it is very complicated, but it does start with education, right? Because at the start of all stigma is a lack of education in society. And so the more we get out there and break down that stigma and educate individuals, hopefully the better the system can get.
Absolutely, absolutely. I want to bring Ms. Lawanda Williams, Professor Lawanda Williams, Chief Behavioral Health Officer at Healthcare. Professor, I have to wonder, when we talk about, as Ms. Kerry Graves mentioned, talking about just the underlying issues of disparities that has seeped into the healthcare system, as issues that have affected Black and brown communities. Now there seems to be a bigger conversation about looking at racism across the board as a public health issue. Here in Baltimore City, as you may already know, Mayor-elect Brandon Scott talks about violence as a public health issue. And so now I'm wondering, does this approach of looking at these long-standing systemic issues and seeing it as a public health issue, will this help us to push the needle forward and finding some real tangible ways that's going to bring some sustainable change? Or are we just kind of going back and forth with semantics and hoping that that it kind of works itself out?
No, I think it's a critically important question. I will say that I think that there is a lot of validity in terms of looking at the issue of racism and more importantly, the impacts of race as a public health condition and phenomenon. And we have seen this sort of thing trend in many other ways. We've thought about, if you think about the opioid epidemic as one example, we have seen that move from a criminal justice issue, right, to moving into a public health space. And so there's certain things that have created that to be. When we think about the opioid epidemic, that for many Black and Brown people was met with handcuffs and with a criminal justice approach until the ramifications of that epidemic started to seep into other communities. And that was sort of the impetus for that starting to look more like a public health crisis. Mm-hmm. And so I think now we're in a really unique space where we have seen in public murders and killings, so much so that it has left such a significant stamp on the psyches of all Americans that we've gotten to a place where we see this as it is, as a true public health crisis and emergency. The thing I think that's novel and interesting about this time and space that we're in right now is that, COVID-19 is a pandemic. But I would contend that we've been living in a pandemic for quite some time. And really, when we talk about COVID-19 being the first pandemic of our time, really in terms of America and its history, racism actually was one of the first pandemics that many of us have been going through, and the ramifications of that has sort of permeated on the DNA of people, over the course of time. Mm-hmm. And so I think one of the things that we have to really be critical and be really intentional about is that it not being a matter of semantics, as you mentioned. The thing that transcends something from being a matter of mere semantics and really moving into a space where there's application is really a matter of will. Right? Because we have resources. There's a fallacy of limited resources, right? If we want to be truly honest. But there are lots of resources available, and how we allocate those resources, that is something to question, right? And I could probably tell you my thoughts on that in another space and time. But, I think one of the things that's really critical for us to think about is how we distribute those resources and how we invest our time in such a way that really bends the needle on this. One of the things that I think that's really important, and services are great, being able to meet with individuals and myself, by training at my very core, I'm a social worker. So therapy is what I do and what I love and what I teach and what I practice. But there is a part of me that clearly understands that I will not be able to therapy my way out of this with my clients. I will not be able to sort of provide services and service my way out of this. What we need, and as an adjunct to a lot of the hands-on services that we provide, is really a change in policy, right? We need policies to change in a way that supports the services that we render to people on a micro level. We need to be addressing issues on all of those levels. We think about this sort of upstream and downstream approach, and we really need to be thinking about how it is that we deliver care and have those policies in place that sort of allow us to demonstrate and live out what we say we're trying to do, right? James Baldwin has this quote. He says, I can't believe what you say because I see what you do, right? And I think that's part of what we talk about when we think about stigma. The reason why people have such difficulty sometimes engaging in care is because that care is delivered in ways that are not embracing, that are not culturally sensitive. And that sometimes is a lack of knowledge, and I think, in other spaces, our system has sort of been set up in such a way based on a legacy and a foundation of supremacy and to be quite honest, of structural racism that's sort of embedded into the system. And so I think we propel these things as a product of how we sort of breathe and function and live. And we really need to take a step back and critically look at a lot of the policies and structures that are in place, such that we can start to dismantle those things, so that we truly say we are wanting to be client-centered, that we want to be non-stigmatizing, that we want to be non-judgmental, and provide care that allow people to not just survive, but to thrive and heal. Then we need to take a deep look at how we're doing things. And we need to have policies that support the work that people are doing on the ground, for sure.
Professor, I'm wondering, as I reflect on the type of summer that we've experienced here in 2020, which many would call it a summer of reckoning, when it comes to like racial justice and police brutality. But I'm wondering, you mentioned will, and I, even from the election, the national election, where we are still seeing the country being very much divided on things that are, I would think it'd be pretty blatant. You have one group of folks that say, hey, the president should go back into office regardless of the things that his personal politics and all of those things. But then you also have another group that's saying, hey, it's time for us to change. And I'm wondering, how much longer are we going to find some level of reconciliation, some level of solution, get to another space if we can't even agree on the simple things, that the things that are like blatant and in our face, some of the things that the president has put out, blatantly racist, blatantly biased, and all of those things, but there's still a group of people that says, hey, I can go along with that. So when you're talking about that level of will, even when you're talking about in political leadership, that political leadership is still beholden to the big money. We saw that in this national election, and again, that this was the most expensive election in the history of the United States. President-elect Joe Biden, was $1 billion candidate. And so when we're talking about will, I have to ask this question: whose will are we talking about here?
Well, as a social worker and as a grassroots person at my core, when I talk about will, I'm really talking about the will of the people, right? And I think part of it is that we have conversations around the conversation. So okay. I think many times we're talking about issues that are happening, but we're not really calling it what it is. When we talk about people being disenfranchised and intentionally sort of kept out of things like voting and all of those things that strategically are set up to sort of separate and divide, we have to have conversations about what it really is. And I think also too, we have to think about where the commonalities are between us, because I think there really is much more in common between us than there is that separates us. And I think that when we think about issues of health equity and issues of race and class and all of those things, we have to think about what's good for one. Like, I have conversations very often with people, and at Healthcare for the Homeless, we are actually doing quite a bit of work around racial equity and inclusion right now. And one of the things that we talk about quite honestly is that what's good for Black and Brown people is good for everyone, right? So when we right certain injustices, when we look at issues around pay equity and making sure that people are paid, people in the health, the workforce that are actually working with people on the front lines and doing great, tremendous work with COVID-19 and putting themselves at risk. When we talk about health and pay equity for individuals who are doing that work, everybody benefits. So and I think having that kind of conversation and thinking about the structural issues that come up as being just that. So I think when we talk about race, we really think about it as this individual thing. So people get very guarded, because when you think about being complicit in racism, right, that seems like a really heavy charge on someone, because you internalize that as being about me. Yeah, and I think the thing that we have to think about more broadly is the fact that when we talk about racism in particular, it's a product of a system. It's embedded and baked into a system that is, centuries and centuries and centuries old. And so it is infused in the way we live and breathe and the ethos of America, right? And that doesn't make you as an individual a bad person. It's a matter of you functioning in a system that has been created over time. And I think as we start to sort of shift our thinking around that, I think that helps to get us on that trajectory.
Yes, ma'am. Absolutely. Lawanda, thank you so much, Professor. We want to bring in our final voice, our last but not least, Ms. Sharon McClernan, who serves as the Vice President of Clinical Integration at LifeBridge Health. Ms. McClernan, when I think about all that Ms. Williams mentioned, talking about will and most importantly, policy, and we're thinking about those big healthcare companies that are in existence right now. You work at a big healthcare company, Ms. McClernan, LifeBridge Health. How is LifeBridge and in those that you're working with, the other healthcare companies, are they hearing and are they understanding? Are you guys like seeing all of these level of disparities, and how was LifeBridge Health in particular responding to the changes of the people's will and the call for change in policy and structural racism in the system in general?
Yeah. Well, first of all, all people deserve access to appropriate care, no matter what their socioeconomic, race, color, whatever that is. And one of the things we've been really working hard on, and I think that that Mr. Torsch mentioned it, is social issues getting in the way of people's ability to take care of themselves, right? So, we have all of these social determinants of people's health that we haven't for a very long time in the healthcare system really taken a good hard look at. We treat people's medical conditions, we treat people's behavioral health conditions, but we don't always focus on the things behind all of those conditions that are impacting their ability to take care of themselves. Mm-hmm. So we have done a lot of work on really working with throughout the state with the Maryland Hospital Association and others to address those social determinants of health and what is it that's getting in people's way of taking care of themselves. So one of the things that we really have been focused on recently is looking at identifying where there are high areas of social disparity, and especially during the COVID pandemic, we've done a lot of work going out into communities where there is high risk individuals that are in high vulnerable areas, and doing that outreach and making sure that they have the things that they need. But in addition to that, making sure all of our providers, in addition to asking questions about their medical condition, are also focusing on some of the social issues. Do they have a place to live? Are they able to pay their gas and electric bill? There's key questions we're able to ask people. And we have a survey through the American Hospital Association that allows us to really hone in on those things and help people address some of those issues. It's very important that we not only look at people's medical condition, but all of the things that are going on around them to help. And I also want to speak to something that Dr. Joo mentioned, and that's the ease of use of the healthcare system. We realize that over many, many years, the healthcare system has become way more complex than anyone could ever imagine. And folks, particularly those with a behavioral health condition, it is very difficult for people to navigate the healthcare system. Mm-hmm. So we are really working hard. One example that I want to bring forward tonight is an effort that's going on in Baltimore City, Baltimore County, Howard County, and Carroll County. There's a regional partnership that is going to address the needs for people with behavioral health crisis. And the goal of that is to develop a regional system-wide call center where people who are having a behavioral health crisis can call confidentially. They don't have to come to emergency room, because let's face it, our emergency rooms just are not equipped oftentimes to deal with people they don't have the appropriate trained professionals there 24/7 to address people's behavioral health issues. So this call center will allow us to disperse mobile crisis teams to people's homes. And we're working in partnership with law enforcement so that we have the appropriate professionals on site to deal with their mental health crisis, and we're able to get them connected to same or next day treatment. So it's just beginning. We're at the very beginning stages of this, but we do have funding for this effort, and we're really looking forward to getting some good results from that.
Ms. McClernan, I'm wondering just very quickly, in terms of the healthcare system being able to become flexible and being a little bit less rigid.
Yes.
You know, based on your personal experience, what's the timeline for that to happen? Is that going to be at the quote unquote speed of government, or is that going to be 10 years down the road? And really, what is going to need to happen? We got a new administration on the national level. We're going to get a new administration here on the local level in Baltimore City. In a couple of years, we're going to get a new state administration. Does any of those changes, will that kind of accelerate the healthcare system to being a little bit more responsive to the needs of the people?
So I think so. I do believe that though, minus government, I will tell you, I have been in healthcare for over 35 years, almost 40 years now. And I will tell you that just in the last 3 years, I've seen significant change in how we're trying to look to fix the system in a way, you know, policy aside, and I do agree with the Ms. Williams that, you know, we do need lots of policy change. I fully agree with that in order to move forward. But I do believe that healthcare has recognized that we do need to be more flexible, and we do need to be more nimble. And we are working every day to provide that level of flexibility. Rome wasn't built in a day. So, you know, but honestly, I have seen faster movement in the last probably 5-6 years than I have seen in my entire career. So I'm hopeful.
What has been the catalyst for that fast change?
Well, I will say that here in Maryland, hospitals, because of the way hospitals are reimbursed, we are reimbursed in a system that's called a global budget, which means that we sort of have a guaranteed revenue, and our job is to manage costs. And so keeping people out of the hospital is Maryland hospitals are incentivized to keep people out of the hospital, right? So more and more work as a result of that has been deployed into the community. So we're spending way more dollars than we ever have, looking at how we're coordinating care in the community, how we're looking at those social determinants, how we're keeping people well in the community, in order to, you know, keep people from becoming ill enough to require hospitalization. So that's been one catalyst that I have seen really push a lot of the additional work in our community.
Fantastic, fantastic. Folks, this is the time now. First, I want to thank all of our esteemed panelists for their insight. I wanted to jump into some questions from our watchers here. And folks, again, you can post your comments in our Q&A section on Zoom. On Facebook Live, you can post your comments as well, and we'll try to get to as many of your questions as possible. We have a comment from Jay Fulton for Dr. Branch. What is the status of mental health services in Baltimore County for low-income children and adolescents, Dr. Branch?
That's a very good question, and I don't know what you mean by the status. So I'm going to think that means about the availability. And what I would say to you at this particular time is the fact that the availability for mental health and children and adolescents in Baltimore County, the state of Maryland, and across the United States is very limited. We don't have that many child psychologists to be able to handle the number of kids and children and adolescents that need it. And we definitely do not have as much persons of color who are in those professions. So there are folks out there, but it's very, very difficult many times to find the person that you think would be best for your child. What I would say is a person can call us at the health department. That's 410-887-BCHD. Ask for our behavioral health division, and then we can kind of help and assist people in navigating that path to be able to find someone who that they're looking for and who they think will be best for their child.
Absolutely. Thank you so much, Dr. Branch. This next question, and Ms. Kerry, I'm going to kick the question off to you, but many of our panelists can may be able to chime in on it. Barbara Tunstall checked in and said, how do we keep these issues from suffering compassion fatigue? We've seen the short attention span and low tolerance from the majority class when it comes to wearing masks. Blacks have been told through policies and lack of urgency that slavery was so long ago, get over it. How do we continue for the long haul as these issues didn't get birthed overnight? Hence the resolution, it also takes time to change. Thank you.
Yeah, I mean, Lawanda touched on this, I think, when she was speaking as well so eloquently, that these are just such long, these are systemic issues that have been going on for so long. The pervasive racism has been happening for you know, so incredibly long. And, you know, compassion fatigue. Usually when we talk about that, we're talking about that in terms of the first responders right now that are, you know, working in the hospitals and need to be taking care of their own mental health because they've got compassion fatigue over taking care of others. I think this is just our society's responsibility to handle the racism that we've been just dealing with and shrugging off for years and years. So, you know, I can kick it over to Lawanda. You might have more thoughts on that as well, because I know you were speaking to that too. But, you know, I think that these conversations are so important to have right now. And, you know, I hate to hear that there's fatigue around it, because I think they are just, this is the time for us to, you know, to push this forward and get.
Absolutely. I agree. Professor?
Yeah, you know, it's an interesting concept. You're right, Kerry. We talk about this very much in like first responders, also as social workers and therapists. We talk very much about compassion fatigue. You know, I think it's real, but the counter to that is that I think, you know, the reason why we can't tire is because it really is a matter of life and death. And it really is just that cut and dry, right? And so when I am not well, and if you think about ourselves as a community, a global community, and you know, Martin Luther King talked about the beloved community, right? And so if we think about ourselves in that way, when I am not well, then intrinsically you are not well, because I am a symptom and a product of everything that's happening around me. And so when we think about ourselves as part of a global community, you know, I think we have to consider what is illness for someone else inadvertently becomes illness for me. And it really is a matter of life and death. So when I am well, you are well. And I think we have to sort of shift the way that we think about who we are as individuals and not necessarily see ourselves as one unit, but a collective part of a larger unit. And I think that's one of the ways that we keep up the work and keep up the vigor for that work, is to really start to see ourselves that way.
Absolutely. Thank you so much. A registered nurse, Ms. Antoinette Munger, hopefully I'm saying her name correctly. She asked a very, very important question. And Ms. Sharon McClernan, I would like to get your take on this one. The real question that she said is, how do we educate Black, brown people to recognize when they are being victimized by systemic racism? As a registered nurse case manager, having worked in emergency departments in the city and the county, I've had to intervene on behalf of my patients when it was clear they were being treated differently from my Caucasian patients. Because the healthcare system is challenging with its many moving parts, Black, brown people have no clue as to how to address racism when they experience it.
Yeah, and you know, I would say that I agree with her very much, and I do believe that, you know, the healthcare system as a whole. I think that maybe Ms. Graves talked about cultural competence. I think that is very important in our healthcare system. I think we need to be, you know, to continue to have the conversations. I feel that, you know, I'm not really, I guess my answer to your question is I'm not really sure how we go about educating people to respond to racism. I would really more like to focus on how do we prevent that racism and how do we improve cultural competence among our providers and our healthcare teams, right? We need to understand so that that doesn't happen. You know, that's not acceptable. And so I believe that more time should be spent on educating our providers and our healthcare people in our communities so that people should not experience racism and they shouldn't experience differences when it comes to accessing healthcare. Again, and I'll reiterate, all people should have the same access to healthcare. So, you know, I do agree. It happens, and I've seen it happen.
Yeah.
But in my mind, it's not acceptable. Never acceptable.
But let me just say something to that effect, Farajii, if I may.
Sure.
I think it's extraordinarily important that we, as the providers who visualize it and see it, we've got to say something about it. If I'm a person of color and I've been treated the same way all of my life, I don't know how somebody else is being treated. I don't even recognize the fact that I'm being treated differently because this is the way they're treating me. And the person who's treating them that way may not recognize it either, but it's clearly obvious. So that when we get into a position that we're now in the emergency room and we're in the doctor's office and we're in the driver's seat and we're looking at this, that is the opportunity for us not only to educate the patient, but to also educate our colleague as to what their behavior is and why that needs to change. We all see it. It happens a lot. And unfortunately, years ago, many people didn't say anything about it. But the time now is to speak out and to continue to speak out, especially when you know that something is not right. When we look at the Me Too, women have been saying this stuff for years.
Absolutely.
And we've ignored them. Black Lives Matter. We've been saying this for years and people have ignored them. We've got to continue on vocalizing and verbalizing this stuff. And I'm telling you, it's one patient at a time, many a times. It's one colleague at a time. And we've got to educate both sides so that they can all understand where we need to be and what's best, as Dr. Williams said, for our community as a whole.
I want to bring Mr. Torsch back into this conversation as we're talking about speaking up and essentially becoming advocates, because Mr. Torsch, you're working with, again, a vulnerable population of folks who are often written off, unfortunately, who are seen as kind of as second or even third class citizens in some respect. And I'm wondering, how can other citizens become advocates for those individuals who have been, you know, battling drugs addiction and been in that place? What's the best way that folks can become advocates so that way they don't become victimized again?
Well, you know, empowering people, teaching them that it's okay to speak up for themselves, and encouraging them to share their success stories, their stories of recovery, their stories of trauma and how they overcame, how they have healed themselves. Encouraging more peers like myself to work in treatment and recovery and outreach in our ERs, in our jails. The peer support aspect to this crisis is so incredibly important, because when you're meeting people where they are, and I can't remember who touched on it now. I think it might have been Kerry, who, you know, said how easy it would be, you know, for someone like myself or her to find a psychologist or psychiatrist who looks just like us. But for people who are on the street struggling with addiction and mental illness, you know, having that lived experience, looking like they do and feeling like they do, knowing how they're feeling in that moment, really is the game changer, and what really helps open that door of communication and allowing people to access those resources that they might not have accessed if it wasn't for that bonding, that, you know, that sense of camaraderie that they're finding with the peer.
Absolutely. I appreciate that, Mr. Torsch. Thank you so much. Another question that's came in. Baltimore City has, and this is from Jay Fulton, Baltimore City has the Healing City Act. Does Baltimore County currently have any initiative on a countywide level to begin to address systemic racism, particularly as a public health issue? Dr. Branch?
We continue to work on this every day. It is very difficult because we have the systems in place that you've got to break down. So yes, we are working through this each and every day, and we're trying to make it such that people can actually get the help that they need from a medical perspective when they need it. So we've got a lot of programs that we have at this particular time, and all I can say is we're doing it step by step by step, and it takes one day at a time each time. But it's not going to be something that is going to be quite fixed, poof, very, very quickly.
Right, right. I'm going to bring Dr. Jin. Dr. Jin, when I'm listening to some of these things in terms of policy, in terms of the importance of having different conversations, and it makes me think back to what you were talking about in your work with the geriatrics, with the elder community. I feel like that there still needs to be some more advocacy that needs to be done on that side as well. Can you give us some insight as to what does that advocacy look like, especially when you're talking about Black and Brown elders? What are ways to decrease barriers and engage those minority older adults in the healthcare issue and the healthcare system?
Yeah, in some ways it's not very different from the general population. People, it's a great point that you have to educate both sides. And often healthcare systems aren't patient-centered. So often what I try to do with patients, I have to say, is let them know, really do empower them as a physician to say, what do you think and what do you want? And also listen to the language they use and think about what their priorities are, rather than focusing on the disease or the treatment that we're trained to provide. So one thing that's really, really obvious to me after practicing medicine and doing research is that the medical culture is a thing in itself, and professionals kind of provide care as if your everyday regular person knows what you're talking about. But we have jargon, we have ways of thinking about the body and disease, which everyday people don't share. And I think it's just important to recognize that, so that you actually hear your patients and you prioritize what they're concerned about. And so I think people should recognize that when they're having an appointment with a doctor, to empower them to really voice their concerns and to ask questions, to get second opinions, and to really understand that they're the patient, it's their body, it's their health at stake, and that physicians may have their expertise, but they also have limits. So sometimes at the core, patients need to hear that, whether you're an older adult or a young person or a middle-aged person. So I think that's really important, to understand that they have some power too. They're the consumer, and often physicians are consultants. Obviously, if you're in an emergency room and an operating table, you obviously don't have any choice. But if you're in a primary care setting or an outpatient setting and you're a client, you're a consumer and you have choices. And
it's interesting, Dr. Jin, because the narrative about our relationship to the doctor is almost as powerful as our relationship to God in some respect. Yeah. Like when the doctor says you should do something, right, you don't ask questions, you should just do it.
Yeah.
But you're saying the doctor, the physician is like a consultant, which means to me that I can accept your advice or I can decline your advice.
Yeah, I mean, I think you have to take it into context. As I said, if you are having a condition that requires, like I said, operating table, emergency room, shock trauma, cancer, you obviously still have to take into account your needs and considerations. But when when the physician has that level of expertise, you're obviously listening.
Right.
But people go to their doctors all the time who are not in acute situations, don't need acute care. Their life isn't threatened. And they're battling chronic conditions that they have to manage every day. And in those cases, what the patient wants, what they value is really important. And it actually is very practical for physicians to listen to that, because patients sometimes won't take their medicine, won't do the things that may improve their health if it doesn't align with their priorities. So all of that is really important.
I want to kind of expand on that for a moment, if you don't mind, Dr. Jin, with some of the other panelists, because I'm interested to hear, how many folks are confident that patients know exactly what they want when they get into the healthcare system, or they at least can identify, what their needs are. I'm just wondering if because that sounds like a much more of an informed space. I think that we all kind of, growing up, at least for me, you're allowed to be guided instead of having a little bit of understanding of what you're going there for. You listen to the doctor tells you what's wrong with you. You go this way. You talk to this person instead of saying, "Wait a minute, hold up. Yeah, I did some research myself. Yeah, your advice is a little bit off based upon where I am in my healthcare needs." So it's interesting. It would be interesting to hear how many folks actually can identify their needs or can say what they want when they get into such a big system like healthcare.
Yeah, and let me just say that so there is a range of health literacy, definitely.
Okay.
And I think that it's really a physician or nurse or social workers, their responsibility to kind of reach out to the patient, whatever, their level of health literacy, and elicit what it is. So often I would say patients don't know, but I think that physicians should try to elicit it in the best way possible and provide that guidance, rather than kind of imperiously saying, "I know what you need, so you should do this," because it's much more nuanced than that usually.
Professor Lawanda Williams, Professor of Health Literacy. I know about financial literacy. I know about some other literacy, but health literacy, that seems much more empowering. That seems like a much more attainable goal when you're talking about bringing some level of health equity.
It absolutely is. And health literacy is absolutely a thing. And probably just as important, if not more, than financial literacy in some spaces. I think, people are absolutely right that, we need to be thinking about how it is we communicate with our patients and our clients in ways that they can interpret and understand, right? So when you're talking with someone, we really have a responsibility. If we know that a person is not going to maybe be able to digest or take in, because the healthcare system is very complex, right? There's lots of moving pieces. And so we have a responsibility, an ethical responsibility, to make sure that we're communicating with people in ways that they can digest that information and make informed decisions based on that. I think, it's absolutely correct to be partnering with patients. When we take a lens that we know better than a person who has lived with whatever it is they live with for however long they've lived with it, the first moment that we think that we know how to do this or live their lives better than they do, and certainly we have expertise that we bring to that space, but we use our expertise to partner with people and to educate and give them information and to give them agency. I would contend that many times people come into healthcare systems not knowing what they need, usually in often cases, especially in my work, because no one's actually asked them what they think they need. I've had some of the most interesting experiences with clients over the years when I say, you know, what do you hope to get out of this? What do you want? And these seem like really foreign questions to be asked by someone who supposedly, you know, is the expert in the room. When you sort of stop and say, you know, how do you see this playing out? What is it that you want for yourself? And really, I think it can be quite empowering, you know, to be able to engage with someone and in this sort of way that you recognize that they actually do have some agency, and that this is their life, and that they do have some information that could be very useful to making their situation look different, right? And so I think it's really at the very core of health literacy. For me, it really all sort of distills down to respect. You know, I would feel like I'm disrespecting a client if I develop a treatment plan for them without getting their input about it or telling them or being overly prescriptive. It's very paternalistic. And I would feel, you know, like I'm disrespecting the client that's in front of me if I don't get some feedback from them. And the way that you allow people to be able to do that is when you explain things to them in ways that they are able to distill that information, you know, and synthesize it. Yeah.
And I appreciate you saying that, Professor. And Ms. Graves, I'm you know, I want to kind of stay on that space of health literacy, because that seems to be something that I think that would bring people to understanding what is equity, because equity and justice are such big issues. They're big principles. But if you're teaching people or empowering people to take control of their own health, to not allow just the physician to tell you what's wrong, but for you to learn more about your body, to learn more about the things that are affecting your body. I mean, that seems like a very strong positive step to getting people to understand the big principle of equity. Am I wrong in thinking that?
No, I think you're absolutely correct. So at NAMI, we have classes for individuals who are living with a mental health condition, our peer-to-peer class, again, taught by individuals who have been there. And in that class, one of the sessions is dedicated to advocacy and self-advocacy and being your best advocate for you and for what you need. And I think that is so important because, you know, what we know with mental health is that recovery is possible for all individuals living with a mental health condition, but you need early and effective treatment in order to get to that recovery, that place of recovery. And if you aren't advocating for yourself and working through what's going to work for you the best way, you're not going to get to that place. And what looks best, again, for me as a white woman may not be the same as what looks best for Lawanda as a Black woman. So, you know, I think we've got to teach people to advocate for themselves. I think on the clinical side, it's important to train clinicians, as both Sharon and Lawanda were saying, you know, to train clinicians as well. But we have to also teach individuals to advocate for themselves in those situations.
Absolutely, absolutely. One of our watchers, the registered nurse, Ms. Antoinette Munger, put that out there that Health Literacy Month is October 1st through the 31st. And so it's something that we need to kind of celebrate more of. Ms. McClernan, I want to get your take on this whole idea of health literacy. Talk to us about what can, you know, major health organizations like LifeBridge Health, what role can they play in empowering patients to take back their health and to be their own best advocates?
So I think that Ms. Munger put it very eloquently in her comment about, you know, she's a nurse case manager and she spends time advocating for her patients. And I think that we all have to learn to be patient advocates. I believe that, you know, a relationship between a patient and their provider or their healthcare team, it's a partnership. And we have to realize that it's a partnership, but we have to take the time, like Ms. Williams mentioned, to learn what it is that people need. You know, what do you need to get the best results? And what's best for me might not be what's best for you or you or you, right? So we have to make sure that we help people to understand that, and it's okay for them to come to us with what we need, but we have to fully educate them, because I don't think we spend enough time. We have very limited time with patients. Sometimes providers only have 15 minutes with a patient. And so we have to learn to better educate people about what is going on with their conditions, because if they're not educated, they don't know how to advocate for themselves. So more education, related, more time, I guess I don't know where to start other than saying that we as a healthcare system need to understand that this is truly a partnership with our patients, and it is not us. Like I think you mentioned that the doctor's perceived as God. Well, yeah, in some people's minds that what the doctor tells you is gospel, right? And
Right.
we should do it. But maybe it's not what's best for that patient. So we need to understand that and educate and learn that. And it starts with all of us.
Absolutely. Folks, because we are at that 9 o'clock mark, I want to give us an opportunity to share any final thoughts. I'm asking that you each give a 1 minute final thought, final remark as we close out this discussion, which has been very fruitful. I know that there are many more conversations or many more things that we could certainly talk about, but just because it is getting late, and we want to make sure that we respect the time of everyone here. But I'd like to get some final remarks. And Ms. McClernan, since you're up, please share with us some final remarks, some little nuggets of wisdom that we can walk away from this conversation with.
Sure. Well, I'm very interested in continuing the conversation. I am a participant with the Maryland Hospitals Association Health Equity Task Force. So we are always interested in getting the thoughts of others to help us along our journey. So, I would really love to stay connected with panelists and other people on this call. Feel free to look me up. My email is smclernan@lifebridgehealth.org, and feel free to send me your thoughts.
Fantastic, Ms. McClernan. Thank you so much for being a part of this conversation. Mr. Torsch, thank you, sir, for speaking up for those who can't speak for themselves and those who have been impacted by drugs and addiction. Talk to us a little bit about, what do you want us to walk away with from this conversation?
When you see someone on the street who might be struggling with addiction or mental illness, treat them with dignity and compassion. Remember that people are often a victim of their circumstances, and it's not easy to act. It's not always easy to access the services that many of us take for granted. So just love your neighbor, believe in harm reduction, try to reduce the NIMBY. The next time somebody wants to open a treatment center or a Medicaid-assisted treatment clinic or a recovery house in your area, don't fight it. Come to the community meetings, come to the council meetings, speak to people that want to open it. Just try to lift the stigma and just try to remember that, we're all in this together, and 2020 has been hard on all of us, especially for people struggling with addiction and mental illness. So we need this, we need the compassion now more than ever.
Absolutely. Absolutely. Thank you so much for your time tonight, Mr. Torsch. Dr. Jin, what are your final remarks tonight, ma'am?
Yeah, so I think there are some themes about doing things together, and kind of as it seems like we enter a new kind of period with a new president-elect, and and then COVID has kind of taught us how important relationships are and how we're suffering, emotionally, mentally, sometimes cognitively too. Everyone's brain isn't working as well as it used to. And so I think that conversations like this should continue, and that people, try to work on this together. It's I think naturally sometimes are easy to kind of go into camps, whether it be doctors or patients or communities or young people or old people. But as somebody, a panelist said, your health is another person's health. How well you do affects how well somebody else does. And so I think I encourage everyone to think in those terms, and I will try that very hard as well.
How well you do affects what someone else does. And that brings me to you, Professor. Sounds like a great creed to live by. What are your final thoughts, ma'am?
No, I would just say, for folks who are out here sort of, living, dealing with COVID, and particularly for people who are serving individuals during this time and showing up every day and being on the front lines, whether it be in the hospitals, on the streets, in the substance abuse programs, serving individuals experiencing homelessness. It's really an important time to make sure that we're all taking good care of ourselves and being mindful of taking breaks and having balance and really just embracing those things, I think, that bring you comfort and joy, even in the midst of a global pandemic. If there's been no other time to take good care, this is certainly the time. And so I just encourage everyone as we gear up and armor up to serve and be of service and to be in community with people, that you also think about taking good care of yourself as well.
Absolutely. Thank you so much for your insight tonight, Professor. Let's go to Ms. Kerry Graves. Ms. Graves, Executive Director of NAMI Metropolitan Baltimore.
Yeah, thank you. Well, thank you for having me this evening. And I'll just echo really what John and also Lawanda said, which is have compassion for yourselves and for each other right now. Recognize there are just so many individuals who are dealing with signs and symptoms of a mental health condition, and that's understandable right now. And I think the longer this goes on, all of us have sort of lost some of that maybe grace that we had earlier in the pandemic, the grace that we are giving to each other earlier in the pandemic. Everyone's calling this the new normal, and it's anything but normal right now. We are still living in a time that is causing a lot of stress and anxiety and worry. And so being understanding of each other, I can't be the executive director of a nonprofit without also mentioning our services and programs. So if you are in need of programs, just knowing that NAMI Metro Baltimore has virtual support groups for both individuals who are living with a mental health condition as well as for family members, because for family members who are caregiving for someone with a mental health condition right now, this can be an especially challenging time too. So we have free programs. They are all virtual right now, and you can reach out to us at namibaltimore.org and join us for one of those programs.
Ms. Graves, thank you so much for your time. Thank you so much for your insight. And certainly last but not least, Dr. Gregory Branch, Director of Baltimore County Department of Health and Human Services. Dr. Branch, your final thoughts, sir.
Well, thank you, Farajii. I would like to just thank all the fellow panelists for all the great information they shared. The divide created by disparities in healthcare is very wide. However, forums like these keep me encouraged as we work to bridge the gap. So I always ask, what more can I do? And I hope somebody out there is asking, what more can you do? So I have a pitch, and that is for our community health needs assessment in Baltimore County and our region. Everyone who's here, I'm going to ask you to all go and complete our community health needs assessment. It's an assessment that will help to inform the hospitals and public health how to improve services and our health outcomes. So I'm asking everyone to do that. You got to do it by December 11th. The information on how to get to that survey is in your chat. And I welcome everyone to participate, because that is going to make a difference in the lives of the people that we serve. God bless you. And thanks again, Farajii.
Absolutely. And that community health needs assessment is a survey that can be done in both English and Spanish. And Dr. Branch, what's the number for additional questions?
If you have any questions, you can call 410-887-3729. Again, it's 410-887-3729.
Fantastic. I think one of the best things that has been said, I mean, all of you have shared so much great information and knowledge and insight. Just to share a final comment from one of our watchers, they said Taylor Munger said the conversation needs to be had in hospital settings with physicians and people on the front line. Let's keep the conversation going. The simplicity of treating each other as human beings is what it boils down to. And I could not agree with you more, Taylor. Thank you all so much for being a part of the conversation, Dr. William Branch, Dr. Jin Joo, Mr. John Torsch, Ms. Kerry Graves, Ms. Sharon McClernan, and Ms. Lawanda Williams. Thank you so much for the discussion on advancing health equity tonight. Sonia, thank you, and it's back to you.
Thank you, Farajii. Again, thank you for the panelists and audience members for those thought-provoking questions. We want to hear from you, and so we're encouraging you to continue this discussion to advance health equity in our communities, and invite you to our follow-up community conversation next week, where we will be asking for community feedback on the county's health equity definition, on what health equity means to you. And so the Health Equity Task Force is an accreditation project to define how we assess health inequities and disparities in our health department. And looking forward to continuing this conversation next week. And thank you, and I'll pass it over to Brenda with the logistics.
Yes, please go on bcpl.info to register for the after panel community conversation, which will take place on December 8th, 7 to 8 p.m. Come prepared to talk and be heard and share your ideas for advancing health equity through moderated small group discussions with the goal of identifying actionable items to improve Baltimore County. Thank you for those of you who have been riding with us from the very first panel discussion in this series. We thank you for being faithful. For those of you who are just attending for the first time tonight, thank you so much. Thank you to our wonderful panelists for a robust discussion. We have learned so much about the interrelationship between social inequality and health disparities, and the work and responsibility that must be shouldered through health literacy in all of its forms: outreach, stigma reduction, education, moving from semantics to policy change, cultural competency, advocating for patients, correcting your colleagues if they need to be corrected, respect, compassion, such important things. We've learned a lot. Thank you all. Thank you for the wonderful questions from our audience. We wish everybody well, be safe, wear your mask, and thank you. Have a wonderful evening, everyone.